Hi, Amy.
Hello, everybody.
Hi there. Can you hear us okay?
Yes, can you hear me?
Yes, perfect.
Wonderful. Are you still just getting set up in there?
Well, we are ready to go if you are.
Okay. Well, great. Hello, everyone. I'm Amy Bassarino. I am the APM manager at OPCA. We were asked by Waterfall's APM implementation team to give this presentation to your entire staff. We are very happy to do that. We know how important it is for all of the staff members to know about the program and how it relates to their work. So thanks for the opportunity to share. We have a few people in the room here, but I'll go ahead and start actually first, can you confirm that you can see the screen?
Yes, we can see it.
Perfect. Okay, well, I'll start with the two of us that will be presenting today. We also have a couple of others in the room as well. Like I said, I'm the APM manager, and we also have Stephanie. Do you mind introducing yourself?
Sure. Good morning, everyone. My name is Stephanie Castaño. I work for, obviously work for the Oregon Primary Care Association, and I am OPCA's transformation manager and really help support kind of the care model, healthcare transformation side of the APCM work.
Great, thanks, Stephanie. And we'll be your two main presenters today, but we also have two others in the room.
This is Summer Brazil, Administrative Coordinator with OPCA.
And Rob Schlegel, Financial Sustainability Manager with OPCA.
And just a little bit about the OPCA. I know that some of you are engaged with our activities and maybe some of you are not. So just wanted to share that our mission is to lead transformation of primary care to achieve health equity for all. You'll have the slides afterwards, and I'm not going to read all of the words, but just a little bit about what we do. We serve Oregon's community health centers. We advocate on their behalf. We work to connect them, to build capacity within them. And the APM is just one of many different initiatives that we run here at OPCA. And I think that hopefully you know some of this because you are one of the 32 community health centers, but just a snapshot of who we serve, who you are. You know, you provide primary care to 1 in 10 Oregonians, over 5,000 providers and staff across the state. And we really work to deliver care to in rural areas and also to integrate medical, dental, and behavioral health care as well. This is a summary of who is currently involved in APCM. This is okay. Sorry, we just got an auto thing on our webinar. Continuing on, you'll see that Waterfall Clinic is down in phase 7. They went live. You went live July 1st of this year of 2019. It's already 2020, and you'll notice that we already have a phase 8 forming. They'll be going live July 1st, 2020. So every single year, we've been adding more health centers, both FQHCs and RHCs, to APCM, and we intend to continue to expand.
This is Stephanie. I'll just say that a benefit of being phase 7 is that you'll see that you'll have other peers who have been doing it for some time. So during this presentation, if there are more kind of operational questions or questions about the electronic health record, we are happy to connect you with any of those health center peers that you have. So there is kind of a benefit to coming in a little bit towards the end so that you'll have peers that you can connect with and share best practices with.
Very true. Thank you, Stephanie. So we're going to start very, very high level with APCM. Way back in 2011, 2012, we heard from health centers that the payment wasn't enabling them to provide the sort of care they wanted to, that costs were increasing, there was this budget deficit, a lot of reform happening, and a lot of need to show value within health centers. I think that a lot of you have been hearing about value-based pay, and this is really sort of the start of that era. And so what we did is we worked with health centers. We had 3 at the beginning and also OHA, and we launched the Alternative Payment and Advanced Care Model program back in 2013 is when the first 3 health centers went live, and this was our stated goal at that time, and continues to be our goal, to lead the development of and align payment with an efficient, effective, and emergent care model that achieves the quadruple aim in Oregon CICs. And this is only part of course, what everybody's doing, but it's a key part. Some of you might have also, well, I'm not sure what Waterfall has, but some of our health centers in general also have these arrangements with CCOs. But this is a big one. This is with OHA's Medicaid unit, and what it's doing is it is paying, I'll go into the details soon, but paying a capitated rate, which means you're, instead of incentivized to focus on volume, you're incentivized to really take care of your entire patient population.
Oh, real quick, can you hear me okay?
Yeah, go ahead.
For some reason on our side, and we checked all our settings, it's not in full screen. It looks like it's on the preview mode that you would see, where I can see your main slide and your next slide, but it's not broadcasting full screen. It looks like it's like on the demo on the preview side, like you would be seeing it.
Thanks for letting me know. I'm being told right now how to fix this. This one?
I think you can hit that right there. There you go. Let me see if I can get.
Can you minimize
Yeah.
your?
Oops, no, not that.
Okay, actually, I think I have another.
There it is. Okay, it looks good on our side now.
Oh, it does? Okay, maybe there's a delay. Okay. Okay. Thank you for letting us know, and we apologize for that. Okay. Continuing on, this isn't new, and it's not unique to APCM. We are following IHI's triple aim, to provide population health, to improve the experience of care, and to lower per capita costs. And this is a way of getting at sort of whole person care as much as we can within the PPS model. We know that what makes us healthy isn't necessarily addressed by the healthcare system, and that medical services don't always get at things like healthy behaviors in the environment. But this is our step toward offering care that is more whole person and patient-centered. Now, let me see. I'm actually trying to figure out now how to advance my slide. Right here. There we go. And Stephanie.
Yeah, and so I think all of that to say is that, our healthcare system really is transforming, as to what Amy mentioned, to be more whole person care, to really think about our population as a whole. Again, to move from that fee-for-service incentive to more of that outcome-based approach. And so really what we hope to accomplish with the APCM model is that we improve care really by how we listen to our patients and to our environment. So really listening to that data. I know health centers are spending a lot of effort and time from all members of the care team to really collect data in a standardized way that, again, takes a lot of effort. To really understand, again, trends in your population and what really makes them healthy and what does not. And then to listen to patient priorities and understand better their life circumstances and what really helps them stay healthy, or what is keeping them from being healthy. And all of that to, again, provide different types of care. Now that you have some of this flexibility in how you're incentivized to do care, you have an opportunity to transform and to be more innovative and to really listen to the data, to your patients, and to really make some changes. And again, change is a little bit difficult, but if we do think that, again, as you're later in your phase, like a phase 7, that there are peers before you that can kind of share some of those practices. So I think the idea is just to kind of continue to move towards healthcare transformation improvement that's more whole person.
Great. Now I'm going to dive into the alternative payment methodology side, the APM side, and get into some of the technical details. And please do stop me if any of this maybe warrants clarification, because it can get technical really, really fast. But very basically, I tried to boil it down to what we're doing here. And instead of being paid your fee for service, which is your PPS rate for medical visits, and that's really primary care visits, clinics are paid a per patient per month rate. Each rate is clinic specific. So when Waterfall went live, we went through the process of coming up with their very unique rate, looking at their historical utilization patterns and revenue. And now that they have that rate, you are paid that prospectively for all of your active patients, and that should allow you to transfer your model of care away from that traditional office visit because you're off the visit treadmill, and allow you to offer a much more wide variety of services that are potentially unbillable. We'll talk about care steps in a little bit. It is still rooted in PPS law. We had to get a special state plan amendment for this APM. It is still based on PPS, and you must be paid at least PPS, the equivalency of that. Every quarter, health centers are expected to reconcile back to that PPS equivalency to make sure that you're not falling underneath that floor, and that's to protect you. And this is a voluntary program for everyone. It's open to anyone who receives PPS, so that's FQHCs, RHCs, and IHS clinics. It's also voluntary for OHA. When this SPA was put into place, it was clear that it was voluntary for everyone involved. And some more technical considerations, and after I go through a couple more slides, I'll stop and take questions. But it was designed to be budget neutral. So when we spend time doing those rates, we're trying to get as close as possible to what you had received historically for each of your patients, considering your PPS rate and how often those patients are coming to see you. It also must be that managed care organizations, which are CCOs really, those payments remain unchanged. This APM is completely separate from the rest of the CCO payment you receive. This is just your Medicaid wraparound. And any bonus payments you receive are also completely outside of the model. This is an important slide. We talk about carve-outs, and what we're talking about are those things that are continue to be paid fee-for-service outside of the APM model. It doesn't mean that you won't be paid for these things. It just means that you're paid separately, so you'll continue to be receiving your PPS rate. So prenatal OB is carved out, dental is carved out, and specialty mental health is carved out. I wanted to make that clear. There can be some confusion between behavioral health and mental health, and what we're talking about is specialty mental health, and that is decided by the primary diagnosis code. That's what determines whether you'll be paid as part of APM or outside of APM. When health centers join, they agree to include their entire PPS scope of primary care, all of their patients at all of their sites, including school-based health centers. So before I go on to the accountability plan, I thought I'd take some questions a little bit about just the APM. Did anything I say generate any questions for you?
Can you elaborate a little bit more on what you mean by when you said what's carved out?
By carve out?
Yes.
Sure. So I'll go back to that. When we set out to develop the methodology, there were certain things that just didn't fit into this PMPM structure very well. And what you see there, prenatal OB, dental, and mental health, for different reasons, were things that it couldn't easily put into the PMPM rate. The methodology is already pretty complicated, and so, for example, prenatal is very episodic. You know, a woman is pregnant for 9 months, and then she'll have a lot of visits in those 9 months, and then not afterward, typically. And so it was decided, we had one of our health centers in the first three health centers of phase 1 that it was providing prenatal and had concerns about that showing up in their PMPM. So we carved that out. Dental often has their own rates within PPS, I believe. I'm looking at Rob. And in specialty mental health is also something that's difficult to quantify. Also with mental health, we know that there are some FQHCs that have patients that come in just for those services and actually get primary care elsewhere. And so we wanted to make sure that we weren't having an extreme amount of churn for those patients, so we still We have each patient is attributed to one health center at a time, and that's for primary care. And they can still seek healthcare in that health center would be paid fee for service. Did that help at all, or what other questions do you have?
Thank you.
She said that was fine, thanks.
Okay.
Does anybody else have a question?
What other questions? But I'm just going to turn up the volume up so I can hear you.
Can you hear us okay?
Yeah, you're a little bit muffled or something, but I can hear you.
Okay, we're winging it because we're kind of using a webcam in conjunction with a PA system, so let us know if you can understand this, but I'll make sure we hold the mic right up to their mouth. So, any other questions?
So the question that I had real fast on the specialty mental health, you said would be determined on the codes that was used in the original appointment. I was wondering if you could go into just a little bit more detail about that.
Sure, I think I heard that. We're trying really hard to understand. I think you were asking about the specialty mental health primary diagnosis codes. Is that right?
Yes.
Okay.
Yes.
Yeah, so when each health center enters the program, we base the rates upon a set of codes and then exclude those codes, and then it follows that same methodology going forward once you're on the program. So the rates are set based upon only primary care, and that can include behavioral health. Again, it's that primary diagnosis code that determines whether it falls in or out of the program. And so when Waterfall, has, for example, a specialty mental health, and that's the first diagnosis code is specialty mental health, you'll still bill for that to OHA, and you'll be paid for that fee for service. You'll be paid separately from the APM. The APM does not include that service. Does that help?
A little. I think I'm more trying to, because I'm a medical assistant in the building, when my provider requests mental health, I want to make sure that I'm following up with that correctly and that there isn't going to be a certain code that's going to deny this person to be seen by our mental health providers. So I guess
this is Stephanie. I'm just going to repeat back because, again, I think we heard you better this time than the last, but you want to know that if, and you said you were in an MA or an MA, were to refer a patient to mental health, that they wouldn't be denied that care?
My question, can you hear me better now up here?
Yes,
that's
this
great.
is much better. Thank you.
My question there was if there was a certain, I guess what I'm asking is there going to be a certain list of codes that will allow a patient to be seen by the mental health provider versus the ones that will be not provided, and will we be allowed to get that list?
I'm happy to share it again. Renee Taylor should have that list because that's what we went over during the rate setting period, and it's also included at the end of your participation agreement that we'll be talking about in a few minutes. I'm happy to share that again. I hope that those lists of codes shouldn't actually impact patient care, though. You'll be paid either way, either fee for service still or through the APM, but it shouldn't be a matter of not being able to offer those services or not being paid.
Okay, and we adjusted the microphones a little bit better. Can you hear this better?
Yes.
Mm-hmm.
Okay. I pointed the webcam at it now, so if everybody just holds the microphone like you hear me doing it, you should, yeah, there you go. If you can hear yourself about this loud, she should be able to get it because the mic's right there. So, okay, we're ready.
You're ready.
Oh, do you want us to repeat our response?
We're good. Thank you.
He said he's good.
Oh, okay. So
We're
we
okay?
answered the question, right?
Okay, I'm sorry. We're trying to follow. It's still a little bit muffled. So, and if we want to, by the way, let me. I see that there is something in the chat box. That could be another way we communicate.
Can you make
that's that one. Okay, but yeah, so if we really struggle, feel free to put things into the chat box, Excelina.
Okay.
Yeah, and if there are other questions too that come up, because again, we know this is fresh for some folks as well, and again, some technology can get in the way, that feel free to always email, and we can always do this by email or get on a phone call as well. But I think, yeah, just as what Amy said, is that this is just payment-wise, and it's just to kind of give you an idea of where the payment is coming from. But because mental health is carved out, it doesn't mean you're not getting paid for it. It's just getting paid differently, and it shouldn't impact care in any way on the patient's end. It's just more on the billing side.
So just want to double check that the question for now.
I think we're good on that, Amy.
Okay.
Does anybody have any other questions? Okay. Looks like we're good.
Okay. And in that case, I will continue on and talk about the APCM accountability plan. When health centers sign up to join the APCM program, they participation agreement with OHA. And before I talk about that agreement, I'll talk a little bit about how we manage the program overall. It's jointly managed between OHA and OPCA, and I've tried to sort of lay out the differences here on the screen. OHA is the payer, and so you are accountable to them for these agreements, and they are responsible for administrating the program policies and creating necessary reports. Those are usually monthly or even weekly, and they're, of course, the ones to issue those payments to you. And if you have questions about payment or billing, OHA really is the best resource there, and I'm happy as follow-up to provide Michelle and Jennifer's email addresses. Those are our two main contacts. And then OPCA, which is, us, we do a lot of coordination. So we do the onboarding process. Waterfall is just coming to the end of that. We only have one more training, and that's about reconciliation. We also convene the different committees. So that can be the leadership committee, which is made up of all of the APCM leadership. We have in the past had regional meetings where we come out to different parts of Oregon. We had that last year. And then we have various accountability work groups as well. So when there is something to update within the accountability plan, we do that as a collective. So those work groups are OHA, OPCA, and representatives from usually all the health centers that want to participate. We also lead the advanced care learning community, and Stephanie is a lead on that, and she'll be telling you more about that in a few minutes. Since I'm the APM manager, this is Amy, I meet with OHA really frequently, at least weekly, to sort of plan out the shared work, address TA needs between us. It's often that one of us will get a question that's actually better answered by the other party, and we work together to make sure that health centers get what they need. And also sort of plan ahead of time, set the direction of the program based on what we're hearing from health centers, what needs to get done. So the actual participation agreement, when it is signed on, it's for a 5-year commitment, but there actually it's been open-ended. So even the original health centers from back in 2013, they're still on, and that's because we've made updates so frequently that it's always a 5-year open-ended commitment. There is an emergency exit clause for health centers. So far, and this is pretty important to mention, nobody has entered the program and then exited. Everyone who's ever joined the program is still on the program. Which means we must be doing something right, and this must be working for health centers at some level. Again, I already mentioned this before, that this is actually for all sites and all of your Medicaid patients, and it's not just an agreement to the payment methodology, which I've just described, but also an agreement to keep trying to transform your model of care, participate in this community that Stephanie will be telling you about in a few minutes. Make sure you submit your reports as agreed to, and also the last bullet is to also come together, like I said, and work in partnership to keep evolving the model. The model is changing all the time. We're trying to be adaptive to what is needed and what is requested. So there's an agreement that even though you're signing on to an agreement that has certain things now, that agreement will change over time. with, of course, notifications. This is a snapshot of what the quadruple aim looks like. I mentioned before that we use the quadruple aim in our goal statement. It's also the structure now for our accountability plan. So we have quadrants for quality, cost, access, and population health equity. We do work within all of these quadrants and often have work groups going at all times. So for example, just in the last year, we had to pull together the quality quadrant work group in order to come up with a new quality metrics reporting strategy. And that's because the CCO incentive metrics were changed. So I'm going to have to actually change this language. This is what it was at the end of 2019, but it's going to look different pretty soon. We switched to our new quality metrics reporting strategy in July. So as just one example of how frequently things change. In the cost quadrant, we have been looking at total cost of care reports. We did that throughout 2019. The access quadrant, it's really about care steps, which we'll be going over in a few minutes. And the population health equity quadrant has always been our sort of more innovative space to test things out and to try to really push the envelope when it comes to care. And so we've talked a lot about social determinants of health, using data to really dig into your patient population and figure out who you serve, and also partner with community, others in the community to help address patient needs. So I'm actually going to hand it back to Stephanie and then take it back for care steps. So, but Stephanie is going to talk more about the advanced care model.
Yeah, thanks, Amy. So, again, this is Stephanie. I do take the lead on some of the advanced care model work, and what that really means is kind of the work that the trainings and learning spaces that we provide for health centers to come together and kind of share some of their transformative approaches. We bring in leaders from around the country also to kind of share and really help us again move towards that, our North Star, which is health equity for all, and really thinking about the patient as a whole and equal access for everybody. So as you can see on the screen, just some things about what the advanced care model has is that we really focus on the expanded team-based care side of things. I think if anything, that's what we mostly focus on is we know that this is we moved away from just provider to patient, but more to that care team model approach. And so really answering some of the questions about what is good expanded care team practices look like, what are those workflows, how does documentation really fit into some of this work, and who takes the lead on certain practices. So we really look at everything through the care team. We also discuss new methods of engagement, and again, we'll mention a little bit more about what those could look like through care steps. And then really, again, thinking outside of those clinical walls and into the communities, we know that we are more than just our biology and some of our behaviors, but we're really affected by our communities where we work, where we live, where we play. And so really taking that into account and thinking about who to partner in the community to help us better serve some of our patients' needs as a whole. And so a little bit about the advanced care learning community. I know Waterfall has been involved in some of those events, but just to kind of share, since you are all here together in a room, which is exciting, is that the advanced care learning community is a program that covers a couple of healthcare transformation topics, again, with the focus of the evolution of the primary care team. In last September, or in this last year, it's been called different things, but we're calling it the Advanced Care Learning Community. So for folks who might be involved earlier, it's like the Advanced Care Model Learning Community, but it's the Advanced Care Learning Community. And what we've done is to bring a little bit more structure and predictability and consistency to the training, is that we're selecting one topic within OPCA's grant year. So from July to June of the following year, just to provide a little bit more traction for folks to really dive into a topic that's, again, health centers have selected and kind of over the course of a year really continue to learn and share around a topic. So this year's topic that was selected was trauma-informed care implementation. We've had a couple of webinars, we've had a workshop, we have a conference coming up on January 31st to really, it's more beyond what is trauma-informed care, but it's the now what, how do we actually operationalize and become organizations of healing. And so that's coming up on January 31st. For the following topics in September, we engaged your health center leadership and membership to ask you what are some priority topics, in your opinion, that you would like our advanced care learning community to focus on. And we heard really loud and clear that, again, social needs care and community partnership is at the top. Also at the top was preparing for some value-based pay and care. And what does value-based care look like? So you'll see that here's what we kind of have coming up. So again, wrapping up our trauma-informed care stuff in June, and then kicking off with more of our social needs and community partnerships in July. For folks who have been part of our other collaborative, we had something called AHEADS, Advancing Health Equity and Data. So if you were interested and have been involved in some of more of that social determinants of health piece, you might be really interested in what we have coming up next July in 2020. So just a recap of what we've got. Oh, there we go. And then again, just a little bit more context of what to expect throughout some of these topics is that, again, we really look at everything through a healthcare transformation lens, which really means, again, trauma-informed practice. What does patient engagement look like? Because, again, through care steps and through this new capitated payment, engagement is going to be a really key practice for you all. I know some of the health centers who have been part of our APM for a while have to continue to engage those patients to keep them on their list, to keep receiving payment for them. Again, thinking about what an expanded and evolving care team looks like. What are some new modes of access and interaction? Again, thinking about some of those telehealth tools out there. What are some evidence-based practices? How do we document some of the efforts that we do if they're not tied to a service? And then how to look at your data and do something. And then again, addressing health disparity. So a lot to add to these care models, which is again, or to our advanced care learning community, but it's why we decided to select one topic per year so that we can try to touch some of these different lenses throughout the community. And again, I think I shared we are right now in our trauma-informed care implementation topic. We do have a conference coming up. These conferences are really meant for all Oregon federally qualified health centers. So again, the 32 community health centers of Oregon. It's a space for you to share and learn with your peers. We have a really exciting agenda where we have an oral health team from Clackamas County sharing how they've used the trauma-informed care approach and how they provide dental care and access to their patients, and what plans they have with the data that they'll be collecting. We have some really, we have a great panel of health centers who will share how maybe our healthcare system can propagate trauma and what they've done about it, and through a culturally specific lens. And we'll also have even some Oregon Health Center board members and patient advisors to kind of share their leadership in really bringing some trauma-informed practices into their organization. So it'll be a great day, and we have, again, through the advanced care learning topics, we'll have conferences, workshops, and web-based opportunities for folks to check in, because I know Waterfall, sometimes it's hard to get out of your clinic, so we try to provide different forms of TA for folks. So that's all for the advanced care learning community. We do have a web page that I realized I didn't share here, but we can make sure to get out to folks so that you could see what previous TA opportunities we've had, if you'd like to kind of look through some of what we've already done.
Great, thanks, Stephanie. And the advanced care learning community is open to all QHCs, but something that's more specific to the APCM is Care Steps. And STEPS is an acronym. It stands for Services That Engage Patients. And these are all of the ways that you can maintain that engagement with your patients. So once you start receiving your PMPMs, which you are, within 8 quarters, you must engage your patients through either a traditional visit or one of these care steps. And you'll see that there are 4 main buckets: new visit types, education, wellness, and health promotion, coordination, integration, and reducing barriers to health. And I'll be sending out the definitions of all of these in follow-up because they, of course, once again, a little bit technical, but wanted to give you an idea of just all the variety of ways that you can start to provide care in different ways. For example, exercise classes, support groups, Anytime you screen somebody for social determinants of health, that counts as a care step. So it doesn't take a lot to keep people on your list, and you're given a lot of leeway to transform your care in a way that allows you to use some of these new strategies. And I heard before this that there were questions about integration, so I wanted to dig a little bit more into that question and how care steps sort of gets at that. Even though the APM is, of course, focused around primary care, a lot of the care steps do address the fact that there's a variety of different services being offered in healthcare, and in healthcare in your clinic as well. So you'll see on the left side, this is all within that integration bucket. Any time that the health center is coordinating care as far as transitions in care or even for dental, that counts as a care step. Anytime you offer a screening for behavioral health or functional ability, that counts as a care step. And even warm handoffs. And of course, the details are provided in that document I just mentioned that I'll be sending as follow-up. But even those count toward getting you that engagement that you need to keep people on your list. The only thing that's important there is that all of these must involve patients, including warm handoffs, and not just be provider to provider. And then, of course, a lot of the other care steps are also very open-ended and aren't just specific to your primary care teams. Any sort of online portal engagement counts. Advanced technology interactions, so some health centers are texting their patients. That can be from really anybody in your health center. Any sort of exercise class or support group, like I mentioned before, SDH screening. For example, if you use the Prepare tool as part of this AHEAD initiative that we had just, we're doing a second year.
Yeah, so we wrapped up, that's the thing.
Yeah.
So we did wrap up our AHEAD collaborative, which is, again, advancing health equity and data. And so what we're doing for our advanced care learning community in 2020 is to kind of go a little bit more beyond some of the more foundational social needs workflows and really think about how are we partnering with our communities. And so we'll continue that topic through the our advanced care learning community. Thanks, Amy.
Great. Okay, but I mean, that's just another link to other bodies of work that you might be doing that will count under APCM, even though it isn't specifically primary care. And then accessing community resources. That can look like a lot of different things. And I think the point here for that sort of right side of the screen is that anybody in your entire health center, anybody at Waterfall can do these and document these, and it counts as patient engagement. So it really opens up your methods and your care team, what can be considered a care team, I would say. And I'm actually going to hand it back.
Yeah, and so on that note too, I think this is like an image that we've shared, I think for a lot of like intro to APCM, but really what this slide is saying is more about that healthcare transformation piece to better understand your patients. So what we hope you do, or I think what a lot of health centers have really actually done is kind of take a much like a smaller bite out of this whole health transformation piece. I know that it can be very overwhelming to kind of start to implement all of these things all at once, but essentially what this slide is saying is just to start small. Pick a population or pick a provider or whoever is willing to kind of start with some care steps or even some social needs screening, and think about a subpopulation and target them, and then better understand what their needs are and maybe about what kind of care steps that they might need for you to engage them, to connect them to resources, to connect them to providers within your clinic, or if you have community health workers. But really the idea is to start small, to really better understand the needs of your patients and how you might be able to redesign or just improve some of your healthcare transformation care practices. And then also collect data along the way. Collect data along the way to better understand those and share those with others.
Okay. Great. So to pull all of that together, we have at OPCA been trying to quantify what the impacts are, which is difficult to do. So this program's been around, like I said, since 2013. 7 years in. We have a little bit of evidence, including a state analysis that was released back in 2017. The state contracted with an organization called Optimus who ran some pretty, again, technical analyses and showed that 17 million in Medicaid costs were avoided because of APCM over the first 3 years of the program. That gave OHA confidence to move forward with this program, and they still refer to that study from 2017. We have seen modest improvements in quality measures, but I think the most important thing is that health centers have reported being able to make infrastructure investments in data and population health management and those expanded care team members in order to really transform the care that they said that they were hoping at the beginning to be able to do. So that's really positive. We have seen that there's a disproportionate share of those 5-star PCPCHs that are APCM clinics, and this is one that the Medicaid unit likes to share as well about the sort of success story of APCM. I already mentioned that the care teams had been expanded, and that's one thing that has been almost unanimous across the board. So 90% of health centers report that, and to be honest, the other 10 just didn't respond. So we have heard that once you are able to free up your payment from that visit, you're able to really look at different care members that could be offering services instead. And then I think that the care steps are a place that we're always pushing health centers to keep improve that documentation, and keep trying out different care steps. But we did see that the documentation tripled between 2013 and 2017, and we, even since then, I can say without any hard data here, that they've continued to exponentially increase.
Yeah, so what does this all mean? Again, and this is really just to summarize, again, we did provide a lot of details and some broad and some very specific, but what we hope that everybody in the room can really take away is that what this means for patients, care teams, and health centers. And for patients, it's a way to integrate and coordinate care a little bit better. It's for them to know that they have a whole care team behind them to really support them in their healthcare needs, and that there are flexible services that they can use beyond just kind of being a provider. And then for care teams, it means that your efforts will be seen by the entire team, especially for those who don't have those fee-for-service needs. So for example, a community health worker, if you have one, other members of the team's work gets to be seen. You're able to create hopefully more time and more meaningful relationships with patients by engaging them in different ways. And you have the opportunity to really expand beyond the medical domain, so again, beyond the clinical walls, and really impact patient wellness in the communities. For health centers, this is really great for payment. It allows for flexibility and to, again, be able to make some investments in different areas that you weren't maybe allowed or you were restricted from in the fee-for-service model. It enables, again, population health improvements, and you have a predictable revenue support of growth, so you can count on the money that's coming in if you're engaging the patient. And so we really hope, again, that this is a flexible way to really transform care and, again, really improve population health and wellness in your communities without being restricted in the way that payment was developed in the past. Any questions?
Yeah, we wanted to make sure we left plenty of time at the end to open it up. So it looks like we have about 20 minutes. What questions do you have?
Does anybody have any questions about the care steps? Like how it works? In our system, it's called patient touches or care steps. They're the same.
Oh, yeah, good point. So since you are an OCHIN health center, you'll still see that they are called touches within OCHIN, and that's because before we renamed them care steps, they were called patient touches. But yes, you have special screens, special tabs that some of the care steps are automatic, many of them are not. So health center staff members will need to go into those tabs and document care steps as they are completed.
I have a question. I'm wondering, we have a broad array of folks here. We have patient service reps, front office folks, billing, providers, MAs. Could you maybe explain a little bit more how this would apply to every organization, every person in an organization, and what we need to keep in mind as people who aren't generating billing codes or something like that?
A good question. I mean, I think it'll mean different things for different roles within the health center. As far as the front office staff, they actually can be part of the care team if they are, you know, doing care steps. If they are, for example, helping with transportation assistance, they can do that. They can record that, and they can actually have a really significant impact as far as patient engagement. They can keep people on the list. Billing staff, of course, will need to know what to expect back from OHA, like what services will be zero paid if they're included in the APM, and what services to expect fee-for-service payment from. But luckily, OHA does offer TA around that, and it actually has already given, I believe, the billing guide to your implementation team to share. You know, MAs have more flexibility. Stephanie?
Yeah, I was reflecting on the things that I've heard from other health centers and APCM, but yeah, for medical assistance, again, I think to the slide before of like you can count the work that you do and you can show the value of the efforts that you made. Again, MAs have a pretty diverse role depending on how each clinic really operationalizes the role, but MAs do have the opportunity to really count all the work that they do using care steps, whether it's a little bit more clinical or even kind of case management type focus where you're really helping connect patients to resources as well. So it is an opportunity to show the amount of work that you do and the value that you have on the team as well as a really key member of the care team. We also, through the kind of more of the social needs and social determinants of health work, we have heard from other health centers who again are really optimizing some of these roles. Like front desk staff sometimes are trained to kind of share some of the social needs screening and kind of review and enter it into potentially whatever EMR system. MAs also have an opportunity to really again be a part of that social needs screening process, whether it's like conducting the screening, handing out the screening, or inputting some information into the EMR as well. So I think for this, regardless of your role, is that you have an opportunity to show the value of your work through documentation and as a key member of the care team in general. And you might also, again, because of the flexibility in payment, there might be opportunities where you can move beyond, again, some of the more clinically focused things and do a little bit more community population health if that's what you enjoy and is what brought you to the community health center in general. That's what I would add. Any other questions or anything else that we can help clarify?
I see some brains turning here. Some questions, Nicole?
Hi, everybody. It's Nicole Norris. So in terms of the care steps, I'm wondering how set are they? Will there be an expansion of care steps in the future? Because we've had some struggles with trying to figure out where to fit what we do in those care steps.
I see. These ones that you see on your screen now were actually refined down from a much larger list, and that took place 6 months ago. I don't think that there's much bandwidth at the moment between for any of us to revisit them, but I think the point was to capture meaningful patient engagement, and if you think that you are meaningfully engaging with your patients and it doesn't fit into here, I'd like to hear about it, because I think that they are meant to capture all of the ways that health centers could. That we had a pretty big brainstorm. So please, let's get in touch offline, Nicole, and we can see what we can do. I think there's a real, the motivation behind these is just to make sure that it's meaningful two-way person engagement, but anything that fits into that sort of broad category should be able to fit within the care steps.
Thank you.
Stephanie, I'll just add again things that I've heard from other health centers as well around care steps is, and to Amy's point, it was to be broad and meaningful, meaningful engagements. And that might look a little bit different health center to health center depending on what you have, but really it has been meant to kind of be flexible, to really capture the work that you're doing. So I do think that, yeah, having that conversation about like what's not fitting, and maybe it's just a matter of how things were defined that we could probably figure out where they might go.
Yep, and sometimes it also just takes a conversation with Medicaid unit so that they understand what you're doing, and then if you get the okay, then you can document in them that way. So.
Could you guys maybe touch a little bit more quickly on the difference between the behavioral health and the mental health? Because when somebody comes in, they have that warm handoff, I think. Oh, can you hear me now?
Just so they can.
Yeah. You're talking about specifically the warm handoff?
Yeah, and the difference between mental health and behavioral health.
I have the definitions with me. Let me read it out. So the definition, health center provider or health professional conducts a face-to-face introduction for the patient to a provider or health professional of a different health discipline, e.g. primary care physician introduces patient to a behavioral health consultant or a community health worker. And it says use, this care step should be counted when the patient is successfully introduced to the second provider or health professional. That's pretty open-ended to me, and I think that it could actually count for behavioral health or mental health. The important thing there is that face-to-face introduction. Does that help?
Yes, I think it does. Does anybody have any questions about that, the differences there with behavioral health and mental health? Or warm handoffs and the integration? No questions? Okay, I can't think of anything else right offhand either to touch on or any other questions.
Okay. Oh, I just there's a bit of an echo now. I will just say, that we'll follow up with all of these documents, and I'm happy to take questions later as they arise in your health center and you're actually trying to implement all of this. The conversation doesn't have to end here in any way.
Right, thank you so much. Yeah, we can definitely, as questions arise or come in, we can get those to you and coordinate that. I really, really appreciate you guys taking your time to do this for us.
You're welcome. We're happy to engage with the entire staff.
Yeah.
It's actually, it's pretty special for us.
Yeah, thank you for making the time. We know how difficult it is to get everybody from your clinic together, and so this has been great for us to be able to have this data to share.
All right, well, thank you again. Can't thank you enough. This has been so helpful.
Oh, good. Well, thanks all of you. Have a great rest of your day. Still morning time. Yeah.
All righty.
Bye.
Thank you.
Thank you.